progresses, and it is ultimately terminal. It was discovered in 1906 by Dr. Alzheimer, who had a patient and described what he was seeing, and actually diagnosed it on autopsy finally when this patient died. After diagnosis, and a lot of people don't know this, but after you're diagnosed with Alzheimer's disease, you can expect to live on average about another 7 years. And very few people, probably 3% of people, live to beyond diagnosis to about 14 years. So it is, relatively rapidly fatal once you get the diagnosis. 27 people worldwide have the disease, about 5 million people in the United States, and that number is expected to quadruple by the year 2050. In response to some of the remarks David made, people are living longer now than they used to, and we are going to have a lot more people in nursing homes and a lot more people being diagnosed with this disease within the next few decades. Every year it costs the United States about $100 billion, and a lot of this is sucked up in long-term care and very expensive medications and testing for these people. Alzheimer's disease occurs in stages, and it starts out mild and then becomes progressively worse over this 10-year period, basically, about a decade worth of progression. So we're going to talk about some of the stages. There's 4 different stages, but this chart is pretty informative since it kind of gives you an idea of some of the stages of the disease and the symptoms as the disease progresses. And you see that MMSE over there on the y-axis of this graph, and that stands for Mini Mental Status Exam Scores. And the Mini Mental Status Exam is an exam that we commonly use in the clinic that has a series of questions that measures a person's cognitive abilities, basically. And what we know about the Mini Mental Status Score is that it correlates with the progression of the disease. So you can see as those Mini Mental Status score numbers start to go down, you can predict just about where these people are in the progression of their disease. So it starts out in the early phases with just some mild memory loss, and we'll talk a little bit more about these stages as we progress on. But you watch the slope of the curve too as we advance from an early stage to a moderate stage. So as we get into this more moderate stage disease, you can see the slope of the line gets a lot steeper. And you start to see the loss of activities of daily living, that's the loss of ADL. And then we start to see behavioral problems toward the end stage of that phase. And then finally, the severe and late stage disease occurs after about year 6 or so. And normally by the time you're at the end of the mild to moderate phase, you're usually in a long-term care facility and pretty debilitated both from an activity standpoint and from a mental standpoint. So the initial stage we call pre-dementia, and this is actually pre-diagnosis a lot of times. And my patients would show up with just some complaints that their memory is not what it used to be. They'd forget where they put their keys. They couldn't remember a person's name. They'd have periods where they'd be driving and they couldn't remember, what street they were supposed to turn off on, that kind of minor memory loss. We also call it by another name, mild cognitive impairment, or MCI. You'll also see that written in some of the literature if you get into reading about this. But this stage may also have, besides memory loss, some changes in attentiveness, some inabilities to think abstractly, and then also activity levels tend to decline in this stage. In other words, they just don't feel like doing some of the things that they normally used to do. Then we move on to stage 2, which is called early dementia. And at this point, the symptoms are becoming somewhat worse. And at that point, usually you can make a diagnosis of Alzheimer's disease. We'll talk about how we diagnose it here very shortly. The symptoms at this stage include not only memory loss, but we're starting to see some language difficulties. We're also seeing some difficulty in executing some movements. In most people, older memories tend to be less affected than some of the newer facts or memories that they tend to grab onto. So these newer things tend to be lost a lot quicker than older memories. And you can kind of see that when you're talking to them and doing their exams and stuff. They'll focus on memories that they know well, and that tends to be things that happened, you know, decades previous to when we were asking them the questions. These people are still at this stage able to communicate pretty basic ideas, but there is a shrinking of their vocabulary, and you're starting to see some decrease in their word fluency. They're just not able to say what they want to say at the rate that they'd like to say it. So the third stage then is moderate dementia. And at this point, we're seeing some pretty progressive deterioration, which eventually hinders their independence. And you'll kind of see this progressing as we go through this stage and into the next stage. But their speech difficulties become much worse at this stage, and they just can't remember the right words to say. It's becoming very difficult for them to communicate. In addition, their reading and writing skills are also starting to be a lot worse than they used to be, and they eventually will be lost completely. Motor skills become very difficult here in moderate dementia, eventually resulting in an inability to do just simple activities of daily living, like, you know, brushing their teeth or washing their hair or bathing, just things that you would normally do around the house without even thinking about them. These people have a lot of trouble executing that. The memory loss at this stage is getting to be quite profound, and this is the stage where, and you see this on television a lot during the Aricept commercials, where they're having trouble recognizing their close relatives or their grandchildren, even their brothers and sisters, or even their spouses. They can't remember their names, or they don't even recognize them. And the behavioral impairments at this point probably haven't been that bad in previous stages, but now these behavioral impairments are becoming really obvious. You're starting to see what we call wandering. There'll be just spontaneous crying that occurs. These people will start to get aggressive, be hitting or maybe even biting people. And then you'll see some resistance, like it's like they have a mind of their own, and they don't want you to help them, and they become increasingly mad if you get in their way and that kind of thing. Oftentimes by the end of moderate dementia stage, most of these people are in long-term care facilities, completely dependent on caregivers. The last stage is called advanced dementia, and this is the final stage. And during this stage, people are almost always completely dependent on caregivers, and typically in a nursing home or some other long-term care facility. Language is often reduced to like single words at this point, and they're almost not able to communicate at all if they speak at all. At this stage, there's real extreme apathy and exhaustion. They need assistance with nearly everything they do. And at the end of this stage, in the mid-stage, they're eventually bedridden and find themselves unable to feed themselves or even turn over in bed. They're quite debilitated. And then finally comes death. Usually death is caused by some other complicating diseases such as pneumonia or infections from bed sores, ulcers, GI problems, that kind of thing. Even heart attacks and strokes, are not uncommon to be seen at these late stages. So what causes it? Well, since 1991, the cause of Alzheimer's disease has been postulated to be what we call the amyloid hypothesis, and this is where what we call beta amyloid protein deposits begin to build up in the brain. And this eventually results in a loss of neurons, a loss of brain tissue, a lot of what I call gumming up of neurologic connections, and eventually lead to a lot of the memory and motor impairments. Well, where do these beta amyloid fibers come from? Well, there's an important protein attached to every one of our neurons, which is called amyloid precursor protein, and we call it APP. And APP serves a real critical role in the brain in regard to normal neuron function and also repair of the neuron if it would happen to be damaged. Normally what happens is that there's a family of enzymes called secretase enzymes, and there's 3 of them. There's alpha and beta and gamma, and each of them have a role in cutting the APP, and this is a normal process that normally occurs. And usually these small fibrils that you can see my pointer on, these are what we call the amyloid the beta amyloid peptides. And they're just small peptides, usually 40 to 42 amino acids long. And normally those dissolve in the liquid around the brain that surrounds the neurons. But in Alzheimer's disease, there's some changes that occur, usually due to mutations that results in an increase in the activity of the secretase enzymes, particularly gamma secretase. So if you look at this second picture over here, you can see these enzymes, which we've depicted as scissors. And this is beta secretase here, and this is gamma secretase down here. And so gamma secretase serves a real critical role, since that's the last cut that needs to be done so that these fibrils begin to form. There's certain things that can increase the activity of gamma secretase, which we'll talk about in the next slide. But the whole process involves too many of these fibrils becoming insoluble in the brain and eventually forming sheets and then eventually plaques, which then causes neurological damage. So this is sort of a depiction of what eventually happens. And as these fibrils conglomerate and stick together, they tend to form little masses around the neuron and the neuron itself. And actually, when that happens, it can actually kill and strangle off the neuron, which eventually causes the death of the nerve. So in most cases, a lot of people think that if their mom or dad had Alzheimer's disease, that they would eventually inherit it too, but actually that's not true. And the reason that's not exactly true, unless it's linked to some programmed mutation that your family may have, is that there's some mutations that occur for whatever reason to 3 different genes, the most common of which is called the ApoE4 gene. And if those mutations occur, then there's an increase usually in secretase activity, which then leads to more and more of these fibrils forming in the brain, obviously. And one of the very popular reasons that we've been working on is insulin resistance being linked to an increased level of beta amyloid in the brain because of upregulating gamma secretase. So if gamma secretase enzyme is functioning at a higher level, then it's going to be SNPing APP at a much faster rate and result in more and more of these fibrils being available to conglomerate in the brain and cause problems. The next slide, we'll talk about diagnosis. The diagnosis of Alzheimer's disease is probably going to change within the next decade, but currently it is what we call a clinical diagnosis, and that's where the doctor does not rely on imaging techniques or lab tests to diagnose the disease, but instead the doctor has to rely on what we call diagnostic criteria. So there's a list of diagnostic criteria which involve many different things. It could be the mini mental status score, or it could be this other exam that we do called the ADAS-COG score, which is the Alzheimer's disease assessment scale. For instance, if you had a certain score below a certain level on mini mental status, you would meet one of the diagnostic criteria. In addition, there would also be other things like we would measure motor skills, we'd measure other cognitive abilities, their ability to draw a clock face, for instance, with the correct time on it, that kind of thing. So all those things go together, and the doctor makes the diagnosis if a person has enough criteria to meet the diagnosis, what we call diagnostic criteria. We do use CT scans of the brain. We also use MRIs of the brain and even PET scans, which are positron emission type scans, which you can see on the slide is actually a picture of a PET scan. A PET scan is more of a functional scan where you can actually see how the brain is functioning in different parts of the brain. It's essentially it's the utilization of glucose in the brain, primarily with the PET scan technology. So typically we do those images primarily to rule out other neurologic or other neurodegenerative possibilities so that our diagnostic criteria becomes more reliable. These scans are becoming more popularly used now in following people after diagnosis. So we'll probably do a scan at baseline, and then we'll use the scans, not for diagnosis, but we'll use them to actually follow the patient as their disease progresses, so that we can eventually rely on the scans to be more predictive of the disease and eventually be used for diagnosis. But I was just in Vienna this last July at the International Alzheimer's Disease Conference there. We actually presented the results of one of our clinical trials, which were very well received, by the way. And in some of the lectures and some of the posters that we looked at, there are a lot of companies that are working on newer techniques to use imaging technology as a way to diagnose Alzheimer's disease. One of the ways is using PET scans with actual tracers that have an affinity for these beta amyloid peptides in the brain. And so it's essentially, putting like a beta amyloid little magnet in there, and then the PET scan recognizes it. And so if it's attaching to a lot of beta amyloid, that may be eventually a way that we can diagnose it based on the levels of beta amyloid in the brain. We are getting better at measuring beta amyloid levels in the cerebral spinal fluid. We'll do a spinal tap, draw out a little bit of the fluid, and then we can actually measure some of the protein. The levels of those proteins are as yet not very reliable for tracking the course of the disease or diagnosing the disease, but we're getting better the more that we do it. There's actually a company in Minneapolis called Orasi. It's O-R-A-S-I, which you might want to look up on the internet. They've got some interesting technology that's been developed here at the University of Minnesota hospitals, and this is what we call a MEG scan, or a magnetoencephalogram, which is very neat technology. It's basically like imaging an electrocephalogram, or an EEG, which is a brainwave test. So the test actually will give you a digital image of the brain based on brainwave technology. And so they're getting fairly close at this point to getting a catalog of scans of normal and scans of people with Alzheimer's disease. And so the technology is getting better, and that may be a possibility in the future. And lastly, SPECT scans, which are similar to PET scans, are making some headway as well.
Doc?
So the diagnosis, yeah.
Doc, this question was going to wait until the end, but I was just wondering, in the diagnosis, do these beta amyloid plaques have a predilection? Is there like a distribution? Is there a place where they happen, a part of the brain that they occur more often than other places?
We're starting to recognize that, yes, and they'll tend to at first be in memory areas of the brain, which are sort of the temporal areas of the brain, and then we'll get to like the lateral cortices, which is where more of the motor function and motor neurons tend to occur, and then eventually it just basically becomes fairly widespread.
Is that? Do you know why? Do you know why it starts in the temporal regions?
We don't. That's the one thing we don't understand, the predilection for these certain areas of the brain.
Okay.
The speculation is that maybe the activity of some of these secretases are higher in those areas of the brain than in others. So far, we just don't know.
Got it.
So is there any way that we can prevent Alzheimer's disease? And there's probably an article in the newspaper nearly every week that you all have probably seen. So far, there's no real definitive preventative measure for preventing Alzheimer's disease. But some of the things that are noted and have been quite popularly quoted in newspapers and television and newspaper articles have been if you eat a Mediterranean diet, which is fairly rich in oils and nuts and fruits and vegetables and fish, those people are thought to have a decreased risk of eventually getting Alzheimer's disease. The one that's very popularly known is if you engage in intellectual activities, it tends to keep your brain busier, more engaged, keeps your abstract thinking at a much higher level. And people are, one of the things that's commonly quoted is, people that do crossword puzzles into their elder years have a decreased risk of getting Alzheimer's disease. Certainly, if you speak another language, if you're bilingual or even trilingual, quadlingual, your risk of getting Alzheimer's disease is much less. I don't know why, but it may be that your brain is just functioning at a higher level, knowing two languages. There's even a cough. Yeah, go ahead, David.
I was just about to pat myself on the back because that's good for me. I speak two languages.
You're in good shape then, David. Yeah, there's even a study with coffee, of course. People that drink coffee have a decreased risk, and then people who take non-steroidal anti-inflammatories may have a decreased risk as well. These are over-the-counter drugs and other prescription drugs that we use for arthritis, ibuprofen, Aleve, drugs like that.
Could that be because they are anti-inflammatory and therefore there's a connection with inflammation and Alzheimer's?
That's exactly right, and there's actually some drug companies that are looking at, these are actually what we call COX-1 or COX-2 inhibitors, which is the way that they stop or alleviate inflammation. And so there's actually been drug companies out there looking at COX-1 and 2 inhibitors for the treatment of Alzheimer's disease. But you're right, there is a lot of inflammation that goes on, once these plaques start developing in the brain. So now, how do we manage Alzheimer's disease as the progression, the downhill progression starts with these patients? And most of the time, we will divide these into three different categories of treatment. And the first is using medication, which is pharmaceutical category. Second is psychosocial. And the third is eventual caregiving. So let's talk about each one of these individually, and we can tell you what we know about what's available for each of these different management techniques. But the list of drugs that are approved for Alzheimer's disease is pretty bleak, and they really don't work that well either. In my experience, the drugs work well at the beginning of therapy, and then after about 6 months begin to decline in their effectiveness. And there's 4 approved drugs, and you can see them on the screen. Aricept is probably the one that everyone knows the best, which is on television a lot. Exelon, which comes orally or in a patch. There's Razidine, and lastly, Namenda. And the first 3 that I mentioned, cholinesterase, that's an enzyme. So if you can inhibit the enzyme, you can preserve the amount of acetylcholine that's in the brain, and that's important because acetylcholine is a neurotransmitter that carries messages between nerves. And if you increase the levels of acetylcholine, you can oftentimes improve people's memory by having extra amounts of acetylcholine around. So the neurons that they do have left are functioning at a higher level. So three of these are acetylcholinesterase inhibitors. The last one is an NMDA receptor blocker, which is the Namenda. And I'm getting a lot of static here, David. Is that?
I don't know. You were blanking out a couple of times too.
Well,
are you there?
I don't know what it is, but it'll get better.
Let me see if I mute myself. Maybe that'll work.
There, that's better. We certainly do use other types of medications in Alzheimer's patients, of course. We may use antipsychotics to help treat their aggression. We might give them anti-anxiety agents or antidepressants. But the important thing to remember is that there's not a very good treatment regimen for Alzheimer's disease at this point. What a lot of pharmaceuticals like ours are actually looking at are ways of modifying the disease and actually getting in and treating the cause of the disease rather than just using these acetylcholinesterase inhibitors to improve symptoms. We want to finally get to a point where we can either prevent Alzheimer's disease from forming or we can somehow reverse it once it starts. Secondly, are psychosocial interventions. And these are designed to help reduce some of the problem behaviors that occur in these patients. And so we use a couple of, probably 3 different popular techniques. And the first one is what we call reminiscence therapy. And this is where we're actually just discussing some past experiences and having people try to remember what they can remember in an effort to sort of get them to retrieve some of their short-term memory. Secondly, we'll do other things called simulated presence therapies, where we'll show them pictures and then actual voice recordings of close friends or relatives, just to keep their sort of their head and their brain engaged with people that they know and activities that they like to do. And then lastly, we'll use stimulation-oriented therapy, it's called, and this is where we may take them to museums, we may take them to concerts, orchestra halls, introduce them to music, and even bring pets in, especially dogs and also cats. And lastly is caregiving. And caregiving is a method of managing these progressive disabilities that are occurring in these individuals. And caregiving can certainly be done at home by loved ones. And secondly, you can have professional home care where nurses or home nurses come into the home and actually take care of the patient. There's assisted living, where it's not a long-term care facility or a hospital, but actually places where they can live that have an ability to offer them treatments that they wouldn't normally be able to get at home. And then lastly, long-term care facilities like nursing homes and swing beds and those types of things where they can get a higher level of assistance and care. So prognosis we talked a little bit about at the beginning of the webinar. And it's scary and somewhat frightening to think that getting a diagnosis of Alzheimer's disease could mean that you would probably pass away within the next decade. And a lot of people don't understand that, but it's actually true that even less than 3% of people don't make it to 14 years after diagnosis. Men have less favorable outcomes and survival than women. Women do tend to live a little bit longer, in my experience, if they have Alzheimer's disease, than men. Survival very oftentimes correlates with how severe their symptoms are along the way. So if they're progressing rapidly and they're having a much greater decline in their motor activities and language activities, that correlates well with how long you can expect them to live. And then, as I mentioned at the beginning, about 70% of deaths are usually from other causes other than Alzheimer's disease, other complicating diseases like pneumonias and infections and other issues that can usually arise in bedridden people. So lastly, what is happening from a research perspective? Companies like ours are quite engaged in trying to find some way to modify this disease, some way to actually stop it once it starts. And we're not the only ones. As of 2008, there's probably over 400 drug candidates in development and actually in clinical trials. And these are all in this disease-modifying treatment category. And I would say the most common target of these drug candidates is to do one thing, and that's to reduce the amount of beta amyloid that eventually accumulates in the brain. And one way of doing that is to inhibit gamma secretase, inhibit that final enzyme that results in the clipping of APP and that final fibril formation. And that's basically what our drug does, our drug candidate, I should say, the NIC515. Luckily for us, our molecule is a very selective gamma secretase inhibitors. Other companies working with the same sort of technology are quite as selective as NIC515, and that can lead to side effects and other problems because it basically inhibits more than gamma secretase. It's not that selective. So there's quite a few, and we saw this at the conference in Vienna too. There are a number of companies looking at gamma secretase inhibition as a target for their drug candidates. Secondly, interestingly enough, are vaccinations, where we can actually vaccinate. It was just basically like you're vaccinating against the flu, which is basically teaching your immune system to be more aggressive with whatever you want it to fight. So with the flu vaccine, basically, we're giving actual proteins from the flu virus in an effort to trigger the immune system to be more aggressive early on. So if you happen to get infection, your own immune system will take care of it. Well, that same technology can be used against beta amyloid. So if we vaccinate against beta amyloid, we can teach our own immune system to get in there and scavenge these fibrils before they tend to form fibrils and plaques.
Will you need that on a yearly basis as well, or is it just...
It remains to be seen. I suspect the vaccines that are currently being developed would probably offer protection for a longer period of time than a year. But they're so new that a lot of them haven't even been in clinical trials yet, so we don't really know. And then lastly, some interesting technology where we're actually using targeted, monoclonal antibodies, just like we do for cancer therapy, where we're actually building our own antibody towards beta amyloid or towards the plaque itself, and these sometimes are called plaque busters. And so these very sophisticated targeted antibodies can either be probably injected. I don't think they'd be bioavailable orally, but they probably become injected and then would actually go after the beta amyloid directly. So rather than relying on our own immune system to fight it off, we would actually be creating our own antibody that's towards the plaques and towards the beta amyloid proteins. So it's a very, very, very busy field of research. Most of our research is being done with our drug candidate at Mount Sinai School of Medicine in New York, and we've been collaborating with them for probably the past 6 years now. We suspect we have another 5 years of development left. And so we've got one clinical trial under our belt which showed some pretty promising findings. We had less of a decline in cognitive function over about a 2-month period as compared with the placebo control group, and also improvement in mini mental status scores as well. So, so far so good. Companies like ours are dedicated to finding something to help these individuals. It's such a devastating disease, and it is quite an urgent and unmet need at this point. So the FDA is interested in companies that are working on it as well. So we're getting a lot of help and a lot of support from the FDA and from our research colleagues. So we'll just see how it goes over the next 5 years. Well, David, I think that's all I have for this evening. I'm sure open to answer some questions if you'd like.
That would be great. That would be great. Thanks, Dr. Zenk. Just put this up in a minute. Folks, this has been Dr. John Zenk talking about Alzheimer's disease and the new directions that companies like his are going in the management and treatment of the disease. If you have questions, please type them into the box to the right, the floating blue panel to the right of your screen. Dr. Zenk, thank you again. And congrats on a successful showing at Vienna. That's pretty good. So they were impressed with your paper, huh?
Yeah, they a lot of the researchers that we talked to recognized the utility of the molecule that we had, and there were a lot of drug companies presenting there that were actually reporting on their clinical trials, and they were reporting that they failed.
Really?
We saw at least 4 of those, and so the other docs that were there were pretty impressed that there was at least one company that was having some success with gamma secretase inhibition. So they've actually invited us back next year. It's in Honolulu next year, so they've invited us back to present the findings once again, and hopefully we'll have some other results to report at that point on our second clinical trial too. So.
And you said this is going to take about 5 years or so to really get the drug out finally, huh?
Yeah, this drug development is a very long process, and rightfully so. the FDA has to ensure that what you're developing is safe, first of all, and then secondly, that it's effective, and then you really do have to understand how it works, and it has to be tested in large numbers of people and also in different populations of people, both genders, of course, and also many different cultures of people. So it becomes a very laborious process, but I think it's meant to be that way because you don't want to rush it and deliver something that's going to hurt people. So.
Right, of course. Okay, well, it looks like we've had some questions come in. I'm going to ask mine first of all because obviously I've got the microphone. One of the things you mentioned was that there's a correlation between insulin sensitivity and gamma secretase activity. My question is, how come there aren't any drugs or any research into decreasing or increasing sensitivity as opposed to resistance, increasing insulin sensitivity so that those plaques won't form in the first place?
Yeah, that's exactly how our drug candidate got discovered. We'd been working with NIC 515 for about 5 years before Mount Sinai called us and wanted to include it in their testing. And, the folks at Mount Sinai had discovered this link, which is now actually called type 3 diabetes. If you dig deep into literature, you'll find that, we've got type 1 diabetes, type 2 diabetes, and then now what's now called type 3 diabetes, which is insulin resistance in the brain. And they discovered this link, and our drug candidate happened to be very good at decreasing insulin resistance. And so that's how it ended up in their screening pool. And they were testing everything from hypoglycemic drugs that we treat type 2 diabetes with to compounds like ours, and even things that help to increase the sensitivity of cells to insulin. And lo and behold, after about 500 different compounds, ours came out on top, and that's how it ended up in the clinic. So it's a very interesting concept. Insulin sensitivity and insulin resistance does indeed increase your risk of getting Alzheimer's disease. It has a kind of an indirect effect at increasing the activity of gamma secretase, for one thing.
Interesting. All right, well, we have a couple of doctors on this call, so we'll be expecting some tough questions. All right, here's the first one. Is there any objective evidence that works, quote unquote, that conclusively proves how Namibia works, or that shows how Namenda works? Excuse me.
Namenda is kind of a curious drug. It interacts with a receptor called the NMDA receptor in the brain. And diseases like Alzheimer's and some other diseases are involved in what's called glutamate metabolism in the brain. And it just so happens that glutamate has an affinity for the NMDA receptor. And diseases like Alzheimer's disease and others will have sort of an increased glutamate activity going on that eventually causes a cycling or a worsening of the disease. We also see it in Parkinson's disease. We also see it in multiple sclerosis. So by inhibiting the NMDA receptor, which stands for N-methyl D-aspartate, which happen to be the two molecules in the brain that are agonists for this receptor or have an affinity for the receptor, including glutamate, can decrease the overstimulation that's occurring because of the excess amount of glutamate that's in the brain. And so by giving Namenda, we can actually decrease the amount of this overstimulation that's occurring, and it tends to help with some of the symptoms in Alzheimer's disease. And that's about all I know about it.
Okay.
I'm not too familiar with the research behind it. Again, it's not a disease-modifying kind of treatment. It's meant to be, treat the symptoms or help the patient.
Right. And now, are there any major risk factors with Namenda?
Not that I know of, no.
Okay. Here's another question from a doctor. Please discuss the factors of informed consent when doing human experimentation on brain function.
On what?
Please discuss the factors of informed consent when doing human experimentation on brain function.
Brain function?
Yeah.
Yeah, we just finished a clinical trial in New York, and the informed consent is pretty long and fairly complicated, but basically the informed consents for clinical trials involve educating the patient about what they're about to embark on in regard to the clinical trial. So it educates them on not only what the purpose of the trial is, but also the treatments in the trial. And then you have to disclose all of the side effects of the drug that could possibly occur. Then there's a lot of language in there about other risks that may occur because of other procedures that we're doing. Our informed consent gave them the option to have a spinal tap or measuring beta amyloid if they wished. But most of the patients that we had in the study did not opt for that option. But the informed consent is a document that's usually originally written by the principal investigator and the other investigators. And then once it goes to what we call an IRB, or an institutional review board, then they make the final changes, because the IRB is ultimately responsible for the study's effect and the study's risks on these patients, so they have to give the okay to go ahead with the study. So they have the final say on the informed consent, but it's basically a very well-written document that usually is like 6th or 7th grade language that everybody can understand, and certainly in multiple languages too, if it's done in an area where English is not the primary language. But that's basically what it looks like.
Okay. All right, here are some relatively easier questions. Are heavy metals and toxic chemicals part of what can cause the formation of plaque in the brain? Does research show a link?
In my research, I haven't run across that being an excessive risk factor for Alzheimer's disease. Certainly, it comes up a lot when you're reading about prevention, and there's been a few studies that are blaming environmental factors and exposure to pollutants on an increased risk of Alzheimer's disease. It's not a definite cause, but there's some people that have mentioned or have actually looked at some research that says that one preventative measure may be limiting your exposure to toxic outside influences. But that's about the only place that I've ever seen it linked to the disease in any way.
Mm-hmm. Okay. Now, I know we mentioned that inflammation is one of the triggers or associated factors. Now, how about free radical damage? Because someone's asking about things like glutathione. Could they be helpful in prevention? Antioxidants.
Can you repeat that one again?
I mentioned that we had spoken about inflammation being an associated factor, and someone is asking if glutathione would be helpful in prevention. So I guess they're trying to ask if antioxidants in general would be, or if there's a free radical component in this whole Alzheimer's disease in the first place.
I don't think that the inflammation is secondary to oxidation per se. Yeah, I think what's happening in the brain is that once the plaques begin forming, or even once the beta amyloid fibrils tend to occur, it triggers more of the body's own natural sort of inflammatory response, and inflammatory mediators then perhaps rush to the area because of the buildup of the fibrils in the brain. I have not seen in all of my reading where antioxidants have been looked at as a potential treatment or a target for pharmaceutical development so far. But more likely, other types of anti-inflammatories have been looked at, like I mentioned, like COX-1 and 2 inhibitors and anti-inflammatories like that.
Got it.
But antioxidants I haven't seen mentioned very much at all.
Got it. Someone's asking about your website. Do you have a website to view some of your information?
Sure. It's Humanetics Corp. So human and then ETICSCORP.com.
Okay. Thank you. For patients whose personality changes for the good, that is, they become more mild-mannered as opposed to aggressive, does the bad behavior eventually come?
Yes. It may be delayed in those people, but the eventual neurodegeneration that occurs in those areas of the brain eventually lead to more aggressive behavior or behavioral disorders, I should say. Not every one of my patients with Alzheimer's disease became aggressive. I mean, some did, some didn't. But I think it depends on, what they're working with as a baseline. There was an interesting study. You probably heard of the nun study that's been quoted in the literature quite a bit. That was an interesting study of about 100 nuns, and they're all competing to get into this one convent. And in order to get in, and these are like nuns in their 20s, they weren't even nuns yet probably, but they were asked to write a paragraph or an essay on why they wanted to be a nun. And they kept all these essays and then looked at them about 30 to 40 years later, and just to try and get a correlation with their baseline intellectual level and their risk of getting Alzheimer's disease. And they found that the nuns whose essays had poor English, poor grammar, kind of poor thought processes that going into it, got Alzheimer's disease at a much faster rate than the nuns who had baseline essays that were more grammatically correct or had some deeper thought processes in them. So that is more fuel for the idea that intellectual stimulation or being maybe perhaps more intellectually acute as a baseline may lead to some more, at least prolonged survival, or maybe not as severe symptoms, once you get diagnosed.
That's an interesting result.
Yeah, and if you just Google Alzheimer's disease and nun study, it's a really interesting account to read, which was actually done up in this part of the country here too. So it's in Minnesota area.
Wow. Well, speaking about prognosis and progression, why do men have a less favorable survival than women do?
Because women are more intellectually smart.
Whoops.
I don't know. That's a really, every time I read that, I go, no, why in the earth would that happen? I don't know, and I've never seen a good reason for it. But
well, I think I read somewhere that the women have a lot more connections in their brain, and probably they're more social. Also, I think the intellectual part. Women do a lot more reading, I think, in general, than men do, and they are much more. Women are more orally inclined.
Yep,
That's
that would be my best guess is that they tend to be more thoughtful individuals than men typically are. So that level of baseline brain function may put them at lower risk.
Right. Well, I tell you what, these questions keep on pouring in. So, Doc, anytime you want to leave, just type in something to me and let me know. Okay, we don't want to keep you here indefinitely, but apparently there are a lot of people who have questions about this. I guess you were expecting that anyway.
Yeah, it's a pretty popular disease, not only from their relatives who have it, or if they're worried about getting it themselves. So it's a serious disease.
Right. A lot of interest here. All right, here's another question from a doctor. It says the clinical tests for memory loss are fraught with observer bias. How do you address this in your studies?
Yeah, that is a big problem with subjective measures in clinical trials. And the way that we get around it, probably two very prominent ways. And one is that we use standardized questionnaires. And typically in our studies, we've been using the mini mental status exam, of course, and then also the Alzheimer's disease assessment scale. Then we make every effort to get the same investigator administering that questionnaire every time. And a lot of times that's not possible, but we make every effort not to have multiple investigators giving the exam and then interpreting the results. So as much as possible, we have our lead investigators administering these tests. And when you have a single investigator doing a standardized assessment of memory, at least you get, I think, some reproducible subjective measures. If you have multiple investigators or inexperienced investigators giving these exams, then that's when you run into problems with kind of spurious results or results that have a very large standard deviation when it comes to taking a look at the final answers. But that definitely is a reason to be taking a look at some of these more advanced imaging techniques, in addition to relying on more objective measures like serum beta amyloid protein levels and things like that to help augment what we're seeing with the questionnaires. But the questionnaires, the person who asked the question is right. I mean, it is one of the things that we keep very close tabs on in these trials.
That's good. Okay, here's an interesting question. I guess this person knows that the gut has a lot of neurons as well. So his question is, are gastrointestinal neurons also developing Alzheimer's disease? I guess you wouldn't call it Alzheimer's disease if it's outside the brain, but are we seeing amyloid plaques also in the gut of people with Alzheimer's disease? I guess that's the question.
It may or may not be in patients that have Alzheimer's disease. There certainly are amyloidoses, other diseases that present as deposition of amyloid in different parts of the body. Mm-hmm. So that disease process is out there. So it may or may not be systemic. Typically, I don't see that it is systemic in most individuals. And people that have Alzheimer's disease, it's fairly universally limited to the brain. They tend not to have crossover into other types of amyloidoses, typically. But you may see it, but usually I don't.
Got it. Okay. How do you know if a person has Alzheimer's or Lewy body disease?
Just by reviewing the diagnoses that we talked about tonight, which is the way we currently diagnose the disease is by looking at the diagnostic criteria, and then once people become bad enough with their symptoms and they meet criteria, we will couple that with rule out scans and make sure they're not suffering from other types of diseases. But it ends up being very much a clinician-dependent diagnosis, and so they rely a lot on mini mental status exam scores and ADS-COG scores and reports from loved ones on their behavior, that sort of thing. Lewy body disease, happens to be more of an objective diagnosis where you can actually, see the Lewy bodies and pick them up and make the diagnosis. But it's diagnosing Alzheimer's disease is a lot more subjective than that.
Mm-hmm. Okay. So you're saying that someone may actually have Lewy bodies in their brain and not actually manifest the symptoms of Alzheimer's disease?
Correct.
Okay. Can head injuries contribute to AD, Alzheimer's disease?
Not that I've ever seen. Not that I've ever seen. Certainly head injuries can lead to other neurologic diseases, bleeds and strokes and aneurysms and things like that. But this is very much, a metabolic type of disease where there's, the deposition of the plaque that occurs that leads to neuron death. And typically trauma does not trigger that, but rather mutations in certain genes or the inheritance of certain genes can lead to the eventual defect that results in the beta amyloid becoming more prevalent. But I've not run across a link with trauma.
Okay. One of the doctors put a research, a couple of references connecting industrial toxins to insulin resistance and then to brain changes in rats. So I've kind of like put that in the box so everybody can see that. Thanks, Doc. And I'll just send it.
Great.
I'll just send it to everyone there. Okay, so it's in your box, folks. Thanks, Doc, for sending this. Aluminum is often blamed, cookware, etc. Is that valid?
In Alzheimer's disease?
Yeah.
I've seen that. I've seen reference to that. Particularly in patients getting dialysis, tends to be a problem with them accumulating aluminum. And then some of those patients, it's been blamed for neurologic diseases. And I don't know enough about aluminum's correlation with Alzheimer's disease. I don't see it a lot when I'm doing my reading, but I have run across it once or twice, yes.
Okay. Well, Jenny's being a smart aleck here, saying, thanks, Doc, for acknowledging that we are intellectually smarter than men.
That's the only reason I can think of.
Jenny, you are on probation. All right, because someone needs your website again. Can you just give it to me so I can type it out?
Yep.
It is.
It's Humanetics Corp.
Oh, sorry about that.
.com. So it's human and then ETICSCORP.com.
Okay. And that's your website, I think.
Yep, that's our company website. And then there's some information on there about our Alzheimer's drug candidate. So.
Got it. All right. Someone says because women multitask more, that's one reason why they're smart, why they survive better. Okay, here's a question I've been expecting people would ask a long time ago. And I know we talked about this before the webinar came on, and you said it was okay. All right. Are there any natural supplements that could help? Acetylcholine, fish oils, etc.
There's one that I'm quite familiar with that I've actually seen some research on, and that's resveratrol, which is the active component in red wine. And the doctors at Mount Sinai who actually did a lot of our preclinical research actually did what we call transgenic mice. These are mice that get Alzheimer's disease at a predictable and fairly quick rate, and they were feeding them Cabernet Sauvignon, and they actually showed, less plaque formation in the mice that drank wine. They were a lot happier mice, too, by the way. and then compared to the placebo mice. So that's one popular one. I haven't seen any that I'm too convinced that I believe the research at this point. For a long time, people thought ginkgo might be effective, but if you really dig deep and drill down, ginkgo has not been found to be that effective as a preventative agent.
But fish oils probably should. I mean, I would think because they help to build brain cells.
Yeah, and from an inflammatory standpoint, probably a good idea. Haven't seen a lot of interesting research on fish oils and Alzheimer's, but that's one possibility, yes.
Okay. Does insurance currently pay for following brain scans, or is this a research tool only? I'm not sure what she means by following.
Oh, she means, I mentioned that we use the scans to follow people as their progression, and yes, typically insurance does cover that. depending on the type of scan and your insurance company. Certainly CT scans, which are not near as expensive as PET scans and MRIs, tend to be covered, and but they're not the best procedure to follow people long term. But typically, you can find an imaging procedure that your insurance company will agree with and can be used for long-term follow-up.
Okay. Please clarify the nomenclature of dementias. It seems that all dementia these days is being called Alzheimer's. Is that valid?
That's a very good point. There's certainly other types of dementias other than Alzheimer's dementia. Alzheimer's tends to be the most common that I mentioned at the beginning, but we can see dementias with, from many different causes. Could be exposure to heavy metals like mercury, for instance, will cause a dementia. Other toxins can cause dementias. Certainly, other neurodegenerative diseases in the brain can result in the same symptoms that we see with Alzheimer's disease. Could be, for instance, a stroke in a certain area of the brain may result in as much or worse memory loss that we see with Alzheimer's disease. So, the person who wrote the question is correct. There's many, many different types of dementias which are not Alzheimer's disease, and that's why we have these diagnostic criteria. So we can help to differentiate, a mild dementia from someone who's actually got Alzheimer's disease, and that's certainly the risk in diagnosing Alzheimer's disease, is that you make the diagnosis and it's not true. And so that's when you have to be particularly diligent about, ruling out, making your differential diagnosis and then ruling out things that it could possibly be, so that you finally get down to a pretty solid diagnosis of Alzheimer's disease.
Okay. Is there any data on the role of excess cortisol in the development of dementia?
Not that I know of. Excessive levels of cortisol tend to be seen more commonly in depression and also in post-traumatic stress disorder, interestingly.
Right.
Our company is actually looking at a anti-cortisol compound for post-traumatic stress disorder currently. So, but Alzheimer's disease, not so much.
Okay. Is there a relationship between athletic condition and Alzheimer's? I'm not sure what she means by this. Do you have any?
No. I've never seen that correlation. In regard to increased risk of Alzheimer's disease, some of my patients who were more physically fit, did better long term because they started with a baseline kind of, activity level that didn't deteriorate as fast as, people that were more debilitated or had some underlying activity problem, neuromuscular problem, that kind of thing. So, going into the diagnosis being more physically fit probably is not going to decrease your risk, but it may improve your prognosis.
Right. I mean, if you exercise a lot, doesn't that produce chemicals in your body that are more protective to brain cells?
Yes, yes, but it becomes a matter of can you overcome the underlying disease process just with that, and probably not. I mean,
Right.
Once the disease progresses, it progresses down that sloping line, like I showed you on the second slide there, and it's pretty hard to stop the progression once it starts.
Now, someone asked what actually causes death in Alzheimer's disease, and you mentioned a couple of things like is the complications like pneumonia and all that. What would be the most common cause of death?
It's almost always a complicating factor. It's pretty rare that we see, brain shutdown or neurodegeneration of the brain bad enough that it will kill them. So typically what happens is these people end up in long-term care, end up being bedridden, barely able to feed themselves. And then they typically, I would say, number one on my list is pneumonia. They'll get some bad infections like pneumonia and not be able to fight it off. because of the fact that they're, being fed through a tube, there's an increased risk of gastrointestinal perforation, ulcers, GI bleeding I've seen. Certainly inactivity can lead to clots in the leg, which can cause pulmonary embolus, which can cause problems, or just the increased stress of the disease may cause cardiac problems. But typically infections are number one on the list, either a bad urinary tract infection that becomes systemic and they get septic and can't recover, or pneumonia.
Do you know what it was in President Reagan's case?
No. It's a good question.
Well, he was pretty old as well, so.
Yeah, I'll have to look that up. That's a good question.
Can you explain this, please? My late grandmother, who was quite ill with Alzheimer's, and in her home developed a colon issue which was flushed out. Her memory came back for about a week. Could colonics perhaps be a viable treatment?
Not for this disease. No, and that was something, that you tend to see, in these patients, depending on their diet. They can get bowel obstructions. They can get ischemic bowel, which can lead to, decreased motility and obstructions and things like that. But colonics probably not, because of what we just talked about in regard to the predictable progression and ultimately terminal nature of the disease. It's just too much to overcome with therapies that aren't targeted correctly.
Right. And I want to apologize for letting out that laugh. But then again, we do know having a clean bowel does help in some cases, but obviously not any long-term solution to things like that, like this condition.
Yep.
Right.
Well, David, I should sign off pretty quick here.
Absolutely. Gotcha. So, folks, we still have a lot of questions, but we have to let Dr. Zenk go. So we want to say, again, thank you, everyone, for joining us on the webinar. And Dr. Zenk, thank you.
Thank you, David. Thanks to the listeners, and keep drinking your coffee and eating your Mediterranean diets.
And exercising and doing crossword puzzles, right?
And doing crossword puzzles. That's right. Yeah.
Hopefully we'll have you back on soon to talk about
Okay.
your research in other areas as well. So thank you again, and God bless, and have a good night.
Okay, good night.
All right, thank you. All right, thanks, folks. If you have any questions, just send an email. Some of the slides, again, are available to members free of charge, so that's an option. God bless. I'll be back on, tomorrow to talk about the 7 laws of life. What is that? Well, join us tomorrow. Have a good night. God bless.